Hello, my name is Dr. Christoph Corral. On behalf of CME Outfitters, I would like to welcome you and thank you for joining us for episode 3 of a 3-part CME OCAS series on reducing symptoms and restoring function in patients with schizophrenia. What's the latest evidence? Today's episode is titled Recent Clinical Trial Data on the Safety and Efficacy of Current and Emerging Therapies to Optimize Schizophrenia Management. This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians around the globe. I'm a professor of psychiatry and molecular medicine at the Zucker School of Medicine at Hofstra Northwell, and also the medical director of the Recognition and Prevention Program at the Zucker Hillside Hospital, Department of Psychiatry in Glen Oaks, New York. Our learning objective today is to utilize recent data on current and emerging therapies to assess their safety and efficacy in reducing relapse and promoting functional recovery. Let's talk about the outcomes in schizophrenia and different goals and illness phases. When a patient comes to us, they're often exacerbated, and what we want is a response, a reduction in symptoms. On this slide, you can see in black the number of patients, the proportion that either respond, remit, recover, or relapse. In black, the chronic patients. Whereas in red, you see numbers from systematic reviews and meta-analyses of first episode patients, shortened to FES. You can see with our current dopaminergic treatments that downtone dopamine tone in the brain, 1 in 5 to 2 out of 3 patients might have a response, whereas 40 to 90% of first episode respond. So early phase patients respond far better to currently available antipsychotics, and there are even less differences in efficacy and greater differences in tolerability in first episode and early phase patients. However, a response only tells you whether somebody's better, not whether they are well. For that, you need not a relative, but an absolute threshold, and that is called remission. Remission are 6 months of no more than mild symptoms for positive symptoms and for negative symptoms. And that's where we already run into trouble. Less than half of chronic patients will achieve this symptom stability for 6 months or longer of no more than mild positive and negative symptoms. First episode patients still do better, 17 to 81%, but the lower bound of that range becomes already concerning. But our ultimate goal is not symptom reduction, it is getting people back on track functionally. And that is called recovery. Recovery is a state that lasts 1 or 2 years where you have symptomatic recovery, again, no more than mild positive or negative symptoms, or a GAF, a global assessment of functioning, scale score of 65 or higher, plus 3 areas of functionality that are adequate. One is self-care, food, shelter, hygiene. The second one is having at least 1 psychosocial contact outside of the family per week. And the third one is doing something meaningful with one's time. Having hobbies, ideally being in education, or even having unpaid 2 or 3 days work-related activity. And this is where we unfortunately still fail our patients. In a meta-analysis of 50 years of research, there has been no big change in recovery rates, and the median recovery rate was 13.5%. Now, first episode patients who responded and remitted better also did not do better in terms of recovery. Where do we lose patients on the road to recovery? The authors analyzed not only the combined symptomatic and functional recovery, they said, well, maybe we overpromise on functionality. Let's just look at 1 or 2 years of symptom stability. And actually, there was no difference in rate compared to the combined symptomatic and functional recovery. And that tells us what the big problem is in schizophrenia care. It is the relapses. Patients do not stay long enough, stable enough, so that we can rehabilitate them, reintegrate them into society, and that rehabilitation process is severely interrupted. And actually, we now know that relapses have a biological impact in addition to tearing into the psychosocial fabric of the patient's life. We know that after each relapse, about 1 in 6 to 1 in 7 patients will not respond as well anymore as they did before to the same medication and dose. So we are in effect breeding secondary treatment resistance, which is commonly only present in 5 to 10% of first episode samples, which rises to 30 to 40% after multiple relapses. So we need to get it right in the beginning, use medications that are effective but also tolerable and safe, and we need to continue this and try to counter relapses as much as possible by also assuring uninterrupted maintenance treatment. Because when you look at stabilized patients who move over to a placebo and a double-blind placebo-controlled discontinuation study, after 3 months, a third of them were worse enough again to be removed from the study. After 6 months, half of them. After a year, 2/3. And within 3 years, 80% would suffer a relapse. How do our treatments, our currently available antipsychotics, differ in terms of side effects? A most recently published network meta-analysis by Hoon et al. In Lancet shows different rankings of antipsychotics across different side effects. The higher on top a medication is, and the more to the left, the closer it is to placebo. The more to the right it is, significantly worse than placebo. When looking at the 3 dopamine blockade-related side effects, EPS, which is signaled here by use of anti-Parkinsonian medications to the left, akathisia in the middle, and prolactin elevation to the right, we can see that the medications closest to the top are partial D2 agonists because they keep the dopamine flow somewhat open. ABC, aripiprazole, brexpiprazole, cariprazine. And we see the looser binding agents, clozapine and quetiapine, as well as the other penes that have inbuilt cholinergic and histaminergic blockade. At the bottom and farthest to the right, we see first-generation antipsychotics and the dones that are tightly binding to dopamine. But obviously, this is also a dose-dependent and titration-dependent effect. Looking at another side effect cluster, which is weight gain and sedation, we see the opposite. The penes that had been better for dopamine blockade-related side effects, EPS, akathisia, prolactin, now move to the bottom and become the more side effect-prone medications because every pene is associated with histaminergic blockade. Whereas on top, we have again the partial agonists as well as the dones. For QTC prolongation, which is relevant in and of itself, and particularly when we combine different antipsychotics together, which could prolong QTC, or when we combine it with other medications that can prolong QTC. Here we have 5 medications that are not associated with more prolongation than placebo. These include the 3 partial agonists, ABC, aripiprazole, brexpiprazole, cariprazine, as well as lurazodone and paliperidone. What about the safety and tolerability of long-acting injectables versus oral treatments? We give 2 weeks, 4 weeks, 8 weeks, 3 months worth of medication at one time. Shouldn't that be associated with more side effects, more dropouts for side effects? It is not. Why? Because these medications have been formulated to have a slow release over time, where actually the peak levels that oral doses achieve are not as high with long-acting injectables. So there is either the same potential for side effects or lower side effects. When we did a meta-analysis of 119 adverse effects in studies that randomized patients to the same medication as an LAI or an oral treatment, 115 of them, or 97%, were not worse with long-acting injectables, even though all the medication is given once, and you can't adjust so quickly as you would with an oral treatment. Mind you, we would put people generally only on LAIs after we found the right dose that is effective and tolerable during oral titration. There were 3 side effects that were somewhat higher with the LAIs. These included akinesia, which most likely was due to the first generation antipsychotics, which released the medication quickly after the injection. There was more low density LDL cholesterol increase because patients are on treatment, so they can gain more weight than people who are off treatment. And why there was more anxiety, I cannot really explain. But as mentioned before, prolactin levels actually and hyperprolactinemia are lower with LAIs because they are very much related to high levels of the medication. But the ultimate side effect of life is death. And looking at a very large sample of 30,000 patients followed in Sweden in a national database study, where every patient followed in this period of time is included, no randomization bias, full generalizability, and patients were followed for almost 6 years on average, the highest death rate, the fastest mortality, was seen in patients who did not pick up their prescription, who were untreated. Interestingly enough, they had higher mortality than people on medication, not only for suicide and unnatural death, but also for cardiovascular illness related mortality. How come that these medications that don't take, these patients that don't take medications that can cause weight gain, metabolic side effects, still die more of cardiovascular illness? Well, they are sicker because they're untreated, cortisol levels are high, unhealthy lifestyle is high, most likely inflammation and oxidative stress is high, and these patients don't go to physicians to actually treat their risk factors for cardiovascular illness. The second worst outcome was seen with first generation antipsychotics. And the best outcome was seen, the least mortality, in patients who are taking second generation antipsychotics. And the very best outcome actually in those that took second generation antipsychotic long-acting injectables, because they took second generation agents and it was assured that they were on them. So the covert non-adherence, maybe also the pseudo treatment resistance that we sometimes observe when we think patients are taking the medications, but they're not, were not part of that LAI group. In effect, when comparing patients on medication given when LAIs were given versus oral treatment, there was a 20 to 30% reduced risk of mortality. Let's talk about agents that are now in development. Cannabidiol has been tested in independent studies, and 2 of them have shown that there's better positive symptom control than with placebo. A D3 antagonist has been studied in a small phase 2 study, also showing advantages over placebo. Lumateperone is most likely going to be the next antipsychotic approved. It has its date by the FDA in December 2019, and it's a novel medication with a novel mechanism. Generally, antipsychotics that modulate dopamine have the same effect pre- and post-synaptically. They're either antagonists or partial agonists. Lumateperone is a partial agonist presynaptically, stimulating the brake on the dopamine system, thereby toning down dopamine flow, but it's an antagonist postsynaptically. And this medication that has only one side effect more than placebo, and that was sedation and somnolence, will be most likely approved first for acute treatment of general schizophrenia at the dose of 42 milligrams. There have been two PDE10A inhibitors, phosphodiesterase 10A inhibitors, which can indirectly modulate dopamine tone, and in the presence of dopamine blockade, augmentation to antipsychotics, these trials were negative. The nitric oxide donor, which might also help psychosis, was only found to separate in one single study in Brazil. Since then, there have been 3 subsequent negative trials. The so-called TAR1 agonist. In one phase 2 study, there have been very positive results for total PANSS, positive symptoms, negative symptoms, general symptoms, as well as global illness severity, and a trial phase 3 program is currently underway. Positive symptoms are one important aspect, but we have many medications that already help those symptoms. We need better treatments for negative and cognitive symptoms. Roluperidone is a novel entity, which is both a 5-HT2A and sigma-2 antagonist that in one study only conducted in Eastern Europe showed significant effects as early as week 2 for negative symptoms in monotherapy. However, there was also very little placebo effect, which we usually see with negative symptoms when patients are rated over time. So the phase 3 program that is currently underway will have to shed more light whether this is a viable mechanism of action to help negative symptoms. For cognitive dysfunction, cannabidiol has actually been shown not to be effective in 2 small studies. For treatment-resistant schizophrenia, we unfortunately only have clozapine currently available. And unfortunately, one trial program of a D1 preferring D1, D2 antagonist, LuAF35700, has failed. This agent was effective for schizophrenia, but not better than olanzapine or risperidone. Pimavanserin, the 5-HT2A inverse agonist, has recently read out from a study for residual positive symptoms where the overall study was negative, but I would consider this a partial positive study because in 81% of the sample, all sites that had patients in Europe, this medication added to antipsychotics actually reduced negative symptoms, as residual positive symptoms, significantly more than placebo, and also clinical global impression severity improved more than placebo, but not in the entire study when the 20% of patients followed in the US were added. However, when the entire study sample was analyzed, negative symptoms improved significantly better with the 5-HT2A inverse agonist pimavanserin than with placebo. Another agent, a D-amino acid oxidase inhibitor, had 2 positive studies, and that is sodium benzoate, but is currently not pursued by any pharmaceutical company. There have been various movements in the long-acting injectable sphere. Aripiprazole Loroxal nanocrystals, the Initio, has been approved for the starting regime, where 1 injection plus 1 dose of 30 milligrams aripiprazole, in addition to the usual injectable, now reduces the oral co-treatment to just 1 day. There has been another approval of Perseris, which is the first subcutaneous once-monthly risperidone, which also does not require co-treatment orally. There has been a positive European study of a once-monthly injectable risperidone called Doria. And there are 2 long-acting injectables currently under study. The 6-monthly version of paliperidone palmitate, where currently we have only the 1-monthly and 3-monthly available, and the second subcutaneously injected risperidone once monthly, which is studied by Teva. Finally, there have been 2 approvals for side effect reducing medications. the so-called VMAT2 antagonists, vesicular monoamine transporter 2 antagonists, and deutetrabenazine and valbenazine have both been approved for the treatment of tardive dyskinesia. But it's interesting whether or not this could also be a presynaptic treatment for psychosis in and of itself. The final medication I want to discuss is the combination of samidorphan and olanzapine called ALKS 3831, which has shown to have the same acute efficacy as olanzapine versus placebo, and to reduce weight gain versus olanzapine through the addition of a mu opioid antagonist called samidorphan. For the first 6 weeks, there's similar weight gain between olanzapine alone or olanzapine plus the mu opioid antagonist, but thereafter, there's very little, if any, weight gain that occurs in the combination of samidorphan and olanzapine, whereas the olanzapine weight gain continues. And in a recent phase 3 study, both the co-primary and the key secondary outcome were in favor of samidorphan plus olanzapine. There was significantly less weight gain in percent change over baseline, 4.2% with the combined use of samidorphan and olanzapine versus almost 6.6% with olanzapine proper, and also on patients gaining at least 10% or 7% over baseline, there was a significant reduction in risk with the ALKS 3831, and the FDA is also currently investigating this treatment for the treatment of schizophrenia.
Let's summarize with our SMART goals: specific, measurable, attainable, relevant, and timely. That is what we hope that you will take from this discussion to apply to your practice. We hope that you will be able to implement treatment strategies that are safe, effective, and promote remission and functional recovery, and utilize recent clinical trial evidence to identify current and emerging therapies that improve treatment outcomes in people with schizophrenia. Thank you for joining us today for episode 3 of our 3-part CMO cast series. To view additional episodes on the use of long-acting injectables for symptom reduction and restoration of function, as well as differentiating the mechanisms of action of therapies for schizophrenia, please visit www.cmeoutfitters.com.